Welcome back, ladies and gentlemen. We now proceed on to the next event of the day, which is the prestigious Platinum Jubilee Oration, which is by Dr. Ruby Pavankar. Chairperson for this event is Lieutenant General A.K. Jindal, Ati Vishisht Seva Medal, Youth Seva Medal, Commandant Army Hospital Research and Referral. May I request, sir, to kindly take his place on stage. Lieutenant General A.K. Jindal is an alumnus of the Armed Forces Medical College, Pune, and has specialized in community medicine. A thorough academician and intuitive teacher, the General Officer has more than 40 professional publications in medical journals. Under the General's able command, Command Hospital Northern Command was awarded the Army Commander's Unit Citation in 2021, and Army Hospital Research and Referral was awarded the Chief of Army Staff Unit Citation this year.
The co-chairperson for the session is Surgeon Vice Admiral Aarti Sareen, Vishish Seva Medal, Director General Medical Services, Navy. Surgeon Vice Admiral Aarti Sareen is an alumnus of the Armed Forces Medical College, Pune, and specialized in radio diagnosis. Admiral Sareen further went on to complete her super specialization in radiation oncology. With numerous national and international publications, the Admiral is a well-known academician. Her military career has been equally glorious, being conferred with the Vishish Seva Medal. Admiral Sareen has served in various prestigious appointments like Director and Commandant AFMC, DGMS Air, and is at present the Director General Medical Services, Navy. May I now request the chairpersons to kindly take over the proceedings of this session.
Thank you. A deep sense of gratitude to General Narendra Kotwal for giving me the honor of chairing this great session. As always, AFMC is just nostalgia, nostalgia, nostalgia. Having joined this college in 1979, I think these corridors are well known. It's always great to visit them. One started one's career as a fresher in the freshers debate in Bhardwaj. And except for eggs were not thrown at us, but there was enough catcalls to prevent us from coming to Bhardwaj again. And though the DGFM has just said that anything that has to be told requires his approval, but being his batchmate, I think I'll take that waiver. Second term, I don't know if Daljit will recall, I still have a photograph of the now silhouettes called the All India Basketball Tournament, where we did Bhangra together. While he was a good exponent of it, the reason why me and a lot of other batchmates joined through were because we were foodies, because we used to get 2 extra glasses of milk in the evening after the Bhangra. We were also the second passing out parade batch, and we passed out on 24 December 83. Daljit was in khakis and I was in olive greens, and a parade was led in a rock solid style by our erstwhile warden, General V.W. Tilak, who later became the dean of this prestigious college. And yesterday only I was talking to the present day FMCites, and they envied us, primarily because they said, sir, aapke time pe girls hostel was co-located with the boys hostel. I think whoever, it was not a great idea that the boys lost their volleyball court and the girls hostel came up there. And so much for fun. Now let's come to some serious business today. We'll be talking about early life microbial signature in allergic diseases and non-communicable diseases by a very illustrious alumnus of the Armed Forces Medical College. As you are aware, today when we talk of allergic diseases like bronchial asthma, COPD, it is increasing in great proportions. And a large number of you have come from Delhi. And Delhi, celebrates when the air quality index comes from very poor to poor. That's the cause of celebration in Delhi. So you can imagine the plight of the asthmatics and, all those who have these atopic illnesses. And as a public health specialist, you're all aware, metabolic diseases, hypertension, childhood obesity are going up. We are already known as the diabetic capital of the world. And obviously, we are now going to learn something new, that is, early life microbial signature, which is, I'm being told by my microbiologist that up to 3 years, the gut microbia build up. And if these microbia don't build up in the healthy style, whether you take antibiotics or those adverse microbacteria are there, one is more susceptible to allergic diseases and non-communicable diseases. So I leave it to Dr. Ruby to explain the other details, and I request Aarti to kindly introduce the speaker.
Good morning. Good morning, ladies and gentlemen. My sincere gratitude to the Commandant Armed Forces Medical College for giving me this opportunity. I have the singular honor and privilege to introduce my illustrious senior, one of the first people I met when I entered the girls' hostel when I joined AFMC, Dr. Ruby Pavankar, Ruby Matthew to us. Dr. Ruby Pavankar is a very illustrious senior of ours. She is a graduate from the O batch of the Armed Forces Medical College. She did her post-graduation from the BJ Medical College and then went on to do a doctorate in allergy and immunology, an MD and PhD in 1995. As early as that, her work with cytokines has actually resulted in the management of allergies as it is today with so many molecules. In 2012, she was conferred with an honorary fellow of the Royal College of Physicians from the United Kingdom. Her main academic positions have been the professor, Division of Allergy, Department of Pediatrics at the Nippon Medical School, Tokyo, Japan. She is a guest professor at various universities, to name a few, in Japan, China, as well as Taiwan. Her key professional positions: she is the executive director and immediate past president of the Asia Pacific Association of Allergy, Asthma, and Clinical Immunology, that is APAC. She is currently actively involved with the India G20, T20 co-chair in the life, environment, resilience, and well-being as part of the key task force. She remains very busy with meetings of G20, G7. She was introduced by the Prime Minister, Mr. Modi himself, at the COP26, Lifestyle for Environment. She is the first woman president of the World Allergy Organization in the past 61 years. WAO is a global body of 108 countries and societies globally. Her scientific research is absolutely a record. Dr. Ruby has contributed significantly to scientific research on the obligatory role of Th2 type cytokines and IgE in allergic inflammation, and that has formed the basis of key biologicals used today for the treatment of asthma. She has a record 692 publications with an H index of 88 with 48,544 citations to date. She has lectured widely in over 60 countries. She has been an expert at the United Nations at Rio and in biodiversity on environment and health, and engages with the COP for climate change and One Health. Major awards: she was honored with the Pravasi Bharatiya Samman Award from the President of India in 2010, the WAO Gold Medal Award in 2018, and the International Distinguished Fellow Award of ACAI in 2006. She is the editor of the Current Opinion of Allergy, Immunology, Clinical Experience Allergy, International Archives of Allergy, and has authored several books and monographs. I can go on, but for the lack of time, we will now start the presentation. I now request the presenters to share the PowerPoint with Dr. Ruby Pavankar and give her the privilege of the presentation. Ladies and gentlemen, Dr. Ruby Pavankar.
Good afternoon, everyone. It's a pleasure to meet all of you virtually, although I wish I could have been there in person. I would first like to thank Lieutenant General Daljit Singh, DGAFMS, Lieutenant General A.K. Jindal, Commander Army Hospital RNR, Surgeon Vice Admiral Aarti Sareen, DGMS Navy, who just introduced me so kindly, Lieutenant General Narendra Kotwal, Director and Commandant, AFMC, Pune, Major General D. Vivekanand, Dean, AFMC, and Brigadier J. Muthukrishnan, Professor and HOD Medicine, who has done a lot actually to set this up, along with Lieutenant General Aarti Sareen. So I would like to express my sincere gratitude to all of them for having me here. It's such an honor to be speaking at this Platinum Jubilee, and I am so humbled for being given this opportunity. AFMC to me is my life. It was not just the foundation of my career, which has taken me this far in my life, but it was also the foundation of my character building as a human being, as a person, how I should relate to my patients, how I should relate to other people, and how I should relate to science. So, with that, I would like to say thank you very much for this wonderful opportunity, and I'm privileged to start my talk. So, today, my talk is going to be on early life microbial signatures in allergic diseases and non communicable diseases. As you know, environmental and lifestyle risk factors, or the exposome, play an important role in various diseases, allergic diseases, as well as other non-communicable chronic inflammatory diseases. Genetics, we know, play a crucial role in the development of asthma, rhinitis, eczema, food allergy, atopic dermatitis, and a variety of other non-communicable diseases. Pollutants actually trigger as well as even aggravate both outdoor and indoor pollution, aggravate, as we just heard right now, that these diseases are grossly affected by pollutants. Biodiversity, the loss of biodiversity, the basic concept of the One Health, where the human health, the animal health, and the plant and the ecosystem have to be together. We cannot only think of human health. So the loss of biodiversity that we see today, the animals and the plants that are just disappearing, leads to, again, the development of zoonotic diseases like we just had the COVID-19, and the climate change that we are seeing today, again, is influenced by this. Then urbanization, industrialization, Western diet, and vitamin D, lack of vitamin D, again aggravates these kind of chronic inflammatory diseases. What about the microbiota? We know that the human microbiota, I will talk about it in a few minutes, but the diversity and the composition of it are very important. And they are affected, as I will show you, by different factors like the C-section, like antibiotics and dietary factors. So when you talk about the major causes of non-communicable disease, I just covered this in my last slide, but just to wrap up, industrialization, urbanization, reduction of infectious disease, or we call the hygiene hypothesis, changes in our diet, like westernized diet with so much of processed foods that we eat today, changes in the microbiome diversity and composition, loss of protective factors, and loss of biodiversity, as well as climate change. Pollution is not just air pollution, but also water pollution, microplastics. All these play an important role in causing or aggravating these diseases. Biodiversity is, again, enhanced exposure to environmental microbes or microbial load and diversity. We know that agriculture and farming, or the traditional farming, always protects against these diseases, whereas industrialization aggravates it. Anthroposophic lifestyle, like unprocessed foods and so on, again, are beneficial. Unpasteurized milk leads to immune education. And then infections, again, or birth order and daycare also have an influence, or the inverse hygiene hypothesis. When we look at the trends in the prevalence of asthma, according to the gross domestic product, what we see here, we all know that the Western countries like the US and America and the UK and Europe, they had a big peak in the prevalence of asthma and other allergic diseases, as well as NCDs. And then they kind of plateau and they start dropping, as you see in recent years. But if you look at developing countries, it's going up and up, it's rising, it's increasing. And then we see countries like Africa and all, where it was pretty low, but now again, you can see it's rising rapidly. So there's a trend in increase in the developing world on the prevalence of asthma. What do you see about obesity? You see a similar kind of pattern. You can see here that Asia and Africa, there is an increase in the prevalence of obesity in these countries. And this clearly shows that we are actually more affected by these different factors than even the developed world. When we talk about microbiota, the microbiota in the body are more than the number of human cells. And the distribution of the bacterial phyla vary from different sites. And also the interesting part is if you take samples from the lung, depending on how you take it and where you take it from, the microbiome differs. So for example, you take it from the trachea, you take it from the bronchioli, you take it from the main bronchi, it totally changes. The phyla is totally different. So you have to keep in mind this when you do or interpret the results of research studies. What does depleted microbial diversity do? Depleted microbial diversity is related to increased chronic inflammation. How does it work? The previous generation, when things were much better and we had lower incidence of NCDs, there was a vertical and a horizontal transmission of the microbiota. This resulted in the replete ancestral microbiome and a development of a robust immune system, mature immune system. What's happening today and what's in the future for us? There is a decreased vertical transmission, decreased horizontal transmission, decreased maintenance, and this results in an altered maturation of the adaptive immunity and the development of chronic inflammatory and autoimmune diseases. Now, there are so many diseases that are associated with altered microbiomes, some which have a strong association based on the studies, with multiple studies, and those who have just few studies, so they have a weaker association, and they are highlighted here. I'm not going to read all of them, but we just heard nice case discussion on in the gastroenterology, the IBD, and so on. So let's actually remember that all these diseases, in not just allergies, but celiac disease, IBD, Crohn's disease, diabetes, cancer, obesity, all these are associated with altered microbiome. And now let's see what we can understand about allergy. Well, in allergy or asthma, there's a dysbiosis. So there's a qualitative and quantitative composition. So the type of the microbiota are also altered, and so is the quantity of the microbiota. And these both actually cause a dysbiosis. Dysbiosis basically is that there is no homeostasis. When everything is fine and the gut microbiome are normal, then in composition and quality and quantity, then it is called homeostasis. When that is disrupted, we call it dysbiosis. So a depleted diversity precedes the clinical onset of disease, and there is indirect and direct evidence for this cause-effect relationship. There are inconsistent findings regarding microbial species, and so also when we talk about probiotics and prebiotics for treatment or prevention, again, there is inconsistent this thing because you have to go based on the specific species or the kind of this thing. You can't pull all the data together. Mechanisms of host microbiome are again largely unknown, and we have to see, is there a window of opportunity in life? And that's where I talked about probiotics and prebiotics and symbiotics also. Now let's look at the influence of the C-section on the microbiome. Now you see here, this is the red line, and this is the C-section. You can see the first half of the year, first 6 to 12 months, there is actually an altered abundance of the bacterial taxa. And this is over the first year of life. And this clearly shows how C-section affects the microbiome. And then what does it actually do? So by altering this microbiota, it alters the immune metabolic syndrome. So it's an altered immune metabolic syndrome. As I said, it prevents the first 3 years of life are very important because the gut microbiota influence the maturation of the immune system into a healthy person. So it's crucial. We call it the most important parts of a child's life or a person's life on this earth. And then you have the development of food allergies and other allergies, asthma, eczema. Then you also have other Th1 type of diseases, and you have obesity, you have IBD, you have cardiac disease, and so on. So a variety of chronic inflammatory diseases are affected by this kind of C-section. What about antibiotic use? Again, antibiotic use in the first 6 to 12 months, you can see that the microbiota actually maturation is affected. You can see very clearly that there's a reduction in the maturation for those that were exposed to antibiotics. And this is crucial because very often antibiotics are used very randomly and profusely in the treatment in children, especially when they have viral infections. They just pumped with antibiotics by people who are not aware of it. Now, this is our study. We've done birth cohort study 0 to 3 years, and this is still unpublished data, but we're just finalizing it. And we looked at the microbiota across different phases, like day 1, 1 month, 3 months, 6 months, 1 year, 3 years, and so on, up to 3 years. And these were looked at for the gut microbiome, as well as other inflammatory cytokines to see what is the relation, both for the development of allergy and for the development of obesity. So for want of time, I'll just show you the allergy part. So you can see that there's a significant OTU correlation between OTU and allergy, as well as OTU and allergy severity in those who are exposed to antibiotics. And you can see very clearly here, this is with the allergy development and this is with the allergy severity. So taking antibiotics actually in early life, at 6 months, already at 6 months, you can see the development of allergy in these children. What about preterm and full term? We know that preterm infants, there's a lack in the development of establishment of the bifidobacterium dominated intestinal flora. This leads to increased infections like necrotizing enterocolitis and intestinal infections, as well as other chronic diseases like obesity and allergic diseases. Now, in this study, we had 30 preterm and 30 full-term infants and looked at the different factors. We looked at the birth weight, we looked at gestational age, we looked at recovery of the weight, duration it takes to weight recovery, and the COP index, and looked at the bacterial diversity. And here you can see very clearly there's a good correlation between gestational age and birth weight with the bacterial diversity, but no correlation with the other factors. Again, when you look at the type of microbiota that affected, you can see that the relationship between bifidobacterium and gestational age and the relationship between bacteroids, you can see both of them, they are lower in those who have lower gestational weight and lower birth, gestational age and lower birth weight. And you can clearly see that this relationship is strong between bifidobacterium birth weight. In fact, bacteroids, you cannot even find them in those preterm infants that are less than 1,500 grams. So preterm gut microbiota and its impact on allergic diseases, we see that these bacteroids and bifidobacterium are less engrafted in preterm infants. And then they are types of bacteria detected at 1 month of age had 8-4 OTU for full term and lower OTU for preterm infants. The abundance of the bacteria types were positively correlated with gestational age and birth weight, but did not have any correlation with the infection or the physical status of the child or the development of allergic disease at 18 months. Though at 7 years of age, you can see that there was a tendency for a correlation between the preterm infants and the development of allergies at the age 7 years. So basically, intestinal engraftment of bifidobacterium and bacteroids associated with immaturity and engraftment of bacteroids may increase the diversity of intestinal flora. And therefore, this is a window of opportunities. How can we bring back this homeostasis? What can we do to actually bring back this homeostasis to prevent the development of these chronic inflammatory diseases? This is crucial, and a lot of research is going in this area. There are national and international birth cohorts going on, and of course, there are several factors that influence it, but we try to do it under the same protocol with NIH and with other groups together. So having understood this, and the other important fact is I didn't show you the data on obesity, but again, for obesity, you can see that there was reduced bifidobacteria, but there was increased bacteroids. So these are kind of things that you can see that these indicate things. We need further research to really understand how it really applies in and how we can actually bring back that kind of dysbiosis to a state of homeostasis. Now, what are the other potential risk factors for the development of asthma and allergies once the postnatal? We know that early viral infections are one of the greatest cause for asthma in children, So that's one of the facts. Then we have urbanization and industrialization, as I mentioned before. Delayed introduction of foods. I have not shown you today, but this is the EAT study, which is very famous in well-known, done in UK, showing that delayed introduction as compared to introduction at 4 months of age actually showed a difference, and the delayed introduction led to the development of allergic diseases, and so also low dose cutaneous allergen exposure can lead to TS2 type of inflammation leading to allergies. Again, westernized diet can of course affect allergies, but they also, like high fat consumption, can lead to obesity. So these are different factors we need to. And regarding antibiotics, I've already told, and there, of course, I already mentioned about the siblings. So these are different factors that actually play a role in this thing. What about epigenetics? Epigenetics links the environment, nutrition, and microbiome. This is crucial. When we talk about lifestyle, we as clinicians, we always have to realize that we are not only treating disease, we are not only talking about the new therapies that are coming out. We need to look at wellness. We need to look at a holistic approach to how we can bring that good health and wellness to the people. This is crucial. And for that, we need to understand what are the factors that actually influence that and how we can. So that the environment, like climate change and our factors, loss of biodiversity influence, nutrition, what we eat, We say you are what you eat. This is very important. And then the microbiome. So this interlinkage is very, very crucial, and also very crucial for what we consider as One Health. And then you know that the short chain fatty acids produced by the gut microbiome have a protective effect. They actually increase the Th1, so it prevents Th2 disease. These are animal studies done in mice. And then otherwise you can see promote the T regulator. The Treg cells actually are protective. They are like Th1, the Treg cells actually suppress the Th2 inflammation. And so they act as a protection against the Th2 type of phenomenon. So this occurs through CD4 T cells, through histone acetylation of FOXP3, or that's the Treg cell, as you can see here. Again, environmental microbes like Acinetobacter can actually upregulate Th1, downregulate Th2, increase Th2, so it's Tregs, so it actually is protective. Whereas histone acetylation levels of IL-4, IL-13 are increased when an increased Th2 in those that have Ig responses to nematode or house dust mite. So these are factors that we need to know when we understand what exactly influences and what we can do to correct. Now, we talked about the diet and we talked about the high-fat diet. So high-fat dietary intake induces a microbiota signature that promotes food allergy. Now, look at this. These are actually given 12 weeks. They were given a high-fat diet and they looked at the result of that. There's, of course, obesity as well as food allergy susceptibility. But then, and also you can see there's an intestinal bacterial diversity is reduced. And this is again related with this development of this chronic inflammatory diseases. When you actually take this microbiota from them and you do a transfer of the high-fat diet associated microbiome to germ-free mice, and you see what happens there. Interestingly, you see that the transfer of obesity does not happen. That doesn't happen, but there is a transfer of the food allergy susceptibility. Now, these are areas which we need to understand what exactly occurs for having this kind of a difference, even though both are chronic non-communicable diseases. So dysbiosis at various body habitats have been firmly linked with chronic inflammation. We know asthma, eczema, food allergy, nasal polyps, COPD, and so on. And this dysbiosis always, as I mentioned earlier, precedes the disease. Now, when we look at the airways, again, as I said, depending on how you take the samples, where you take the samples from, what is the methodology in which, that changes your results. So if we are comparing two different methodologies, it's like comparing apples to oranges. And that doesn't make sense because then you're interpreting something wrong and you're going in a totally different, wrong direction. Here you can see the outer ring is COPD, the inner ring is the middle ring is asthma, and the inner ring is controlled. You can see, I'm not going to go, there are 7 major species outlined here. I'm not going to go into the details of it due to want of time, but from the color coding, you can see very clearly that there's a clear difference between controls, asthma, and COPD. These are in children, actually, looking at the outer ring for asthma, and an inner ring is controls. And you can see again here, there is a clear difference between the microbial communities in asthmatic airways as compared to controls. Now, when you look at the alteration of the gut microbial population, again, it's risk towards food allergy and respiratory allergies. And when you look at this, you can see very clearly in this data that this is looking at seasonal and food allergies due to peanuts, and this is looking at the Treg cells. Very clearly, bacteroids and bacterial dysbiosis in this cause the most severe form of the most correlation with the development of food allergy and respiratory allergies. Now, the other thing is that you also realize that even there is different type of microbiota. So there are multiple studies, methodologies may be different, but the microbiota, environment factor, and the links to development of food allergy, you can see depending on the type of food allergy, the type of microbiota diversity is different. But some of things are like common, like you can see a reduction in the Clostridia, reduction in the bacteroids, and so on. So I'm not going to go into details of this, but this is just to show that even within a single type of disease like food allergy, depending on what type of food allergy it is, you can have a different kind of microbial dysbiosis. Now, in the gut microbiota and the environmental factor and the link to how do you actually explain that? As I mentioned before this, we already went through the fact of cesarean section, antibiotics, all that. This actually causes the development of food allergies. And this is basically, this results in increase in specific Ig, a reduction in the, increase in the pro-inflammatory cytokines, in the reduction in the anti-inflammatory cytokines, and the reduction in Treg cells, but upregulation of Th2 type of cells, and of course suppress the CD103 dendritic cell function. And when you look at the specific gut microbiome and food allergy and respiratory allergy, you can see these are healthy controls. These are food allergy, respiratory allergy. Very clearly, you can see this is butyrates, and very clearly you can see here again that they are reduced. The microbial diversity is reduced as compared to healthy controls here also. And what is interesting is when they actually are coexisting, you can see again this even further reduced as compared to healthy controls. So when you hypothesize the relationship between dysbiosis, characterized by fewer of the butyrate acid producing bacteria, you can see butyric acid producing bacteria, and the onset of allergic disease. You can see over here, there are different factors. I'm not going through this again because we've already talked about it, but these different factors lead to dysbiosis, a reduction in the butyrate acid circulating bacteria, and this then causes a downregulation of the Treg cells, upregulation of Th2 types, downregulation of IL-10, interleukin-10, upregulation of interleukin-4 and 13, and then you get the allergic disease. And here you can see on this part of the slide, you can see that this is like BAPB is much less in food allergy as compared to healthy controls. So in conclusion, I would like to say the take-home message is there is an increase in allergic diseases and non-communicable disease in recent years, and this is a global phenomenon. Environmental factors, reduced biodiversity, climate change, westernized lifestyle, change in diet all contribute to this increase. The gut microbiota plays a very important role in maintaining host health. The human gut microbiome is established by the age of 3 years and is crucial in the development of a robust immune system. Imbalance of the gut microbiota, termed dysbiosis, occurs due to various factors like C-section, antibiotic use before the age of 3 years, and dysbiosis, leading to greater risk of various non-communicable diseases. And specific microbial signatures are linked to the development of allergies as well as immune tolerance. Dysbiosis is characterized by fewer BAPB, and the onset of allergies is also now understood and considered to be very important. So these factors actually lend us the premise on what we should do. We need more research, of course, but we also need to find ways on how we can bring this kind of dysbiosis to this thing, how we can prevent the insults caused by this, how we can reduce the environmental insults, how we can reduce this by controlling our diet, by what we eat, how nutrition plays an important role. All these different factors have to come. So you have to have a holistic approach, not compartmentalize. A holistic approach to health, and what we call as One Health, is crucial for the future of survival of the human race. And finally, I'd like to invite all of you, especially I'd be very happy if we have of our young students would present their work or at least come and listen if they have not enough data to present at the Apache 2023. This is going to be in Singapore, not far from you. It's from the 23rd to the 26th of October. It's going to be a scientific treat more than anything else. So please do come. We welcome you, and please be in touch with us. We have a junior member forum also, which includes students also. So please reach out to me. I'm always there, and I welcome your approach. Thank you very much.
Can you take some questions, ma'am?
Sure, absolutely, absolutely.
To the house, please. Yeah. Mike.
To close my slide, how do I close it?
Good morning, ma'am. I'm Surgeon Commodore Thergaonkar. I'm a practicing pediatrician. First of all, I'd like to thank you for the presentation because it was truly transformational, in fact, for all of us who are pediatricians. But it's also at the same time raised multiple questions for us. One question is the development of allergic rhinitis and possibly preschool wheeze before the age of 1 year, where guidelines are a little gray. Second is that we do see a lot of childhood allergic rhinitis and asthma where children are on intranasal steroids and inhaled steroids for a long time. And we are not able to, even if they're controlled, we are not able to take them off these drugs. So would the immunotherapies be coming in the future in a larger amount? Because in India, it's still, this practice is not there too much. Third question is, ma'am, regarding breastfeeding, because we do advocate exclusive breastfeeding till the age of 6 months. And the previous rationale given was that chances of food allergy reduce if we introduce, the solid foods closer to 6 months rather than 4 months, I think there may be some paradigm shift here. So, ma'am, I'd request your comments on these.
Thank you very much. I don't know whether I've missed something, but if I missed something, please ask me again. But first of all, to talk about intranasal, allergic rhinitis at 1 year, I know it's very difficult to diagnose allergic rhinitis at that young age, even asthma, for example, because we just go on symptoms like viral infections are the biggest cause of wheezing, in children. So wheezing infant can be, asthmatic, or it must be just an episode thing, and it leads to, of course, asthma. Whether they're allergic or not, that's another phenomenon. You need to actually do the test and understand it, not just from the history. History is important, but you need to have the test to have the critical diagnosis. Whether it's not just blood tests, sometimes you have to do skin tests also, and then generally that is done after 1 year of age. And in case of food allergies, you do food challenge and things like that. So the important thing is to differentiate whether this is allergic or not. Then the treatment also varies. Second of all, intranasal steroids can be given as long as they're indicated according. Some are given as young as 1 age, some are only given after 2 years. So it depends on the particular product that you're using. And yes, they are safe, especially the newer ones, not the older ones like beclomethasone, but the newer ones like fluticasone, furoate, or Nasonex, and so on. They are safe because their bioavailability is very low in the blood, and so they are quite safe and they don't cause any side effects. Whether you can control them I'll tell you, number one problem for this, and I will say, is compliance. And I'm sure you will know it because I have had patients with asthma. We were almost going to put the child on mepolizumab, and then came to know, this is a teenager, then came to know the child was not taking his inhaler. So this is what happens often. There's a non-compliance leading to this thing. So whether sometimes parents feel that the physicians or clinicians are overdosing or something, and they don't give, they're scared of the term steroid. So that is one issue why it could be that, that they may not improve things. So the guidelines actually do say about the use of intranasal steroids and as well as antihistamines, depending on the product at whatever age they can be given. SLIT or immunotherapy, let's say immunotherapy is the first form of biologic or biologic. The first very thing. Now we have many biologics, but the first form of biologic that was, or precision medicine that was, that whether it's SCIT or SLIT. SLIT, yes, is much more easier to use, but again, you need to ensure that the patient is compliant. India still hasn't recognized SLIT, I know that, but we published the World Allergy Organization when I was president, and prior to me also, we published the global guidelines for evidence-based guidelines for SLIT, and I can share it with you. And so we recommend SLIT, absolutely, because it's very effective and very good. But again, we also published one paper, which you should know, which is called that SLIT or SCIT is product specific. If you are taking a product that is not evaluated, that has no evidence, there are no studies that showing that particular product has efficacy, you cannot use it. So you can't have a carpet blanket statement that SCIT is used, okay, SLIT is okay, so we use it because this is a SLIT. That particular product has to show actual clinical evidence through studies. And if there is at least 1 to 2 studies to show the evidence, then we can say that product can be used. So when we use SLIT or SCIT, we need to be careful about that. But yes, this is an important thing, and we're also working with the ministry to try to bring it into India. That's one of the things that we are working on as the Asia Pacific organization also. The other question you talked about, I just missed it in this. What was the third thing you asked?
Breastfeeding.
Oh yeah, breastfeeding, yes. So yes, conventionally we say it's up to 6 months, but this is more recent data that has come up. And in fact, the study was done by Gideon Lack and his group, and it's shown very clearly. They not only had UK-born children, they also had Asians in their study, and showed that the early introduction of the food actually prevents the development of allergic disease. So do not delay it. It's very often, parents feel, okay, I have peanut allergy, so I don't want to give my kid peanuts. You do the test and you evaluate it, and then you and first of all, the biggest evidence is when the child eats and the child has a reaction. That's the biggest evidence. That is and then you can do oral food challenge or something when the child is a little bigger, more than say 1.5 years of age. So if there is no reaction to the food, then there's no need to stop and not give it. And we are proposing, in fact, we're trying to do multinational studies so that we take this to WHO and tell them that, this is not that you need to change this thing. It's okay to do breastfeeding together with it, but you can start weaning earlier. That's the important thing. It's not saying stop breastfeeding, but it says start the foods earlier. That's the difference.
Thank you, ma'am. Can we ask another question or we
Sure,
have
sure,
time?
as many as you want.
I'm asking the organizers. Do we have time? Sorry, we're running short of time. They're giving me those stares. I'll just request General Daljit if he has any questions or any comments.
I can't hear.
Thank you, Dr. Ruby. We knew you as Dr. Ruby, that time Ruby Matthews. Changed from those days. The face has changed. You know, now look like a Japanese professor.
No, I'm so much Indian.
Arigato.
Do itashimashite.
Thank you, General Daljit.
Arigatou
I'll
gozaimasu.
request Aarti to now just sum it up. Yeah.
I would, on behalf of the DGFMS and everyone in the audience here, as well as the virtual, on the virtual platform, I would like to extend our thanks to Dr. Ruby Pavankar for delivering such a fantastic oration on this very, very special occasion of the 75th anniversary of the Platinum Jubilee of AFMC. Your concept on, the changing things that have happened in the world of allergy, the influences of the gut microbiota, and their influence on human health and total health have been taken in very well by all of us. And I'm sure that this will, incite a lot of interest in the younger population and younger scientists amongst us to look forward to further research on these subjects. I would also request all of you to appreciate her effort for this very, very fantastic oration in the usual manner. Thank you so much, Dr. Ruby Pavankar, ma'am. Thank you very much.
Thank you very much. It's my honor and my pleasure. I wish I could have been there in person. I'm so sorry that I had clashes here.
May I now request the chairpersons to kindly present the memento to the speaker.
Please play the. Madam is not here, so we will present the memento to her on her next trip to India when she comes for the G20 meeting in Goa. Thank you very much. Thank you very much, ma'am. It was an honor and a privilege to have you speak at the Platinum Jubilee. Thank you very much, ma'am.
Thank you so much. Thank you so much.
May I now request Lieutenant General Arindam Chatterjee, Ati Vishisht Seva Medal, Director General Medical Services, Army, to kindly present the Platinum Jubilee mementos to the chairpersons. Thank you, sir. May I now request the dignitaries to kindly take their seats in the audience. Ladies and gentlemen, we now have a technical hold for a few moments for setting the stage for the next session.